This presentation introduces the topic of locked-in syndrome that is characterized by quadriplegia and anarthria, with the preservation of consciousness and vertical eye movement. A review of current literature has been conducted discussing a brief history and components of locked-in syndrome. Implications for speech and language pathologists and their role with locked-in syndrome has been included and is the focus of this presentation. There are three classifications of locked-in syndrome: classic, incomplete, and total. Classic locked-in syndrome consists of quadriplegia and anarthria with preserved consciousness and vertical eye movement. Incomplete locked-in syndrome consists of the same characteristics as classic, as well as remnants of voluntary movements other than vertical eye movement. And total locked-in is the complete immobility and inability to communicate with full consciousness. Although typically caused by basilar artery occlusion leading to brainstem infarction in the ventral pons, locked-in syndrome has multiple etiologies. These include hemorrhagic and thrombotic events, tumors affecting the ventral pons, infectious agents, iatrogenic causes, trauma, metabolic abnormalities. At times, diagnosis can be difficult due to the patient sometimes emerging into locked-in syndrome from a coma. A critical aspect of differential diagnosis is the intact cognitive status of the patient. Locked-in syndrome was first described in the modern era by Carnes and Associates in 1941 when describing the case of a 15-year-old girl who had a tumor in the third ventricle that resulted in similar characteristics to locked-in syndrome. The term locked-in syndrome was first used by Plum and Posner. This original definition described locked-in syndrome as a neurological condition in which consciousness may be preserved, but the patient is mute and the only vocational motor activity is vertical eye movements and blinking. Yet this definition of locked-in syndrome was later refined in 1986 to alter the misinterpretation that mutism could imply unwillingness to speak of the patient. The earliest recorded description of locked-in syndrome comes from Alexandre Dumas's novel The Count of Monte Cristo, where he discusses his personal experience with locked-in syndrome. As stated previously, locked-in syndrome has multiple etiologies, commonly basing from a hemorrhage or thrombosis of the basilar artery supplying the ventral pons. Yet, some cases are caused by iatrogenic influences, such as head manipulations, use of drugs, and regional anesthetic nerve blocks. Locked-in syndrome is also not single to one age group and affects older and younger children, as well as older adults. Locked-in syndrome stems from damage and a lesion on the brainstem of the ventral pons. The pons contains important neural pathways between the cerebrum, spinal cord, and cerebellum. In locked-in syndrome, there is an interruption of all the motor fibers running from the gray matter in the brain via the spinal cord to the body's muscles, and also damage to the centers of the brainstem, important for facial control and speaking. Injury to the corticobulbar tract affects certain cranial nerves, and paralysis of these muscles and nerves causes anarthria. Anarthria then causes dysphagia and limits the use of facial expression in communication. The cranial nerves damaged are essential for control of the facial, pharyngeal, and tongue muscles that are involved in speech, vocalization, and swallowing. Because of the rarity of locked-in syndrome, most clinicians might encounter such a patient once or twice during their career, and due to the overlapping features of locked-in syndrome with other neurological syndromes, there are frequent chances of misdiagnosis or delayed diagnosis. When advanced radiological techniques such as CT scans, MRI, EEG, and PET scans became available, they have now enabled clinicians to readily differentiate diagnosis in locked-in syndrome. A main differentiator in locked-in syndrome is the ocular motor exam. Eye movements are characteristically abnormal in acute locked-in syndrome and are best considered as the window to the brainstem. Testing of this can be done through voluntary following of a finger. Prior to the 21st century, There was previous statistics of low mortality rates reported in the 1980s. The principal cause of death was complications. However, with the assistance of recent medical technological advances, these patients may live for a considerable period of time. Most patients with locked-in syndrome will live 5 years or longer. These patients are conscious and most are able to communicate by eye movements, live at home, and function in their daily environments. The rehabilitation of the patient with locked-in syndrome is directed towards developing effective communication and swallowing skills, if possible. Within classic locked-in syndrome, the AEIU alphabet board was used and was developed for use specifically with patients with locked-in syndrome. The letters are placed in color-coded rows on a chart. The assistant calls out a color and the patient will blink if correct. Then the assistant calls out letters in the selected colored row. For patients with incomplete locked-in syndrome and have more voluntary movement, they may have the ability to move a digit or even a forehead that may allow the patient to activate a device such as a laser to point to an interactive computer screen. The patient may then be able to use email, write letters, and use voice simulators to communicate and have complex conversation. Patients with locked-in syndrome commonly suffer from dysarthria, respiratory and breathing issues, and dysphagia. Due to the damages in nerves as well as a tracheostomy because of respiratory damage and tube feeding, intervention is needed if swallowing or respiratory function could be regained. Cognition, attention, and short-term memory are assessed and treated if skills show to interfere with the patient's ability to communicate effectively. Yet, cognition, attention, and short-term memory are not always affected in syndrome. Language pathologists play a big role in identifying a practical system for communication. Some recent developments in brain-computer communications may help with brain-computer interfacing to enable the patient with a classic locked-in syndrome to communicate beyond the AEIOU alphabet board. This form of communication has already proven successful in the case of a 14-year-old boy with classic locked-in syndrome. Devices to aid in communication and other assistive technologies have proven beneficial, as well as allowing individuals to become active members of society. Infrared eye tracking devices now permit affected individuals to use a computer with artificial voice, control their environment, surf on the internet, send emails, and even make phone calls. In some rare cases, if individuals have recovered limited motor abilities, alternate forms of AE devices can be used to hunt and peck or even use a switch to communicate complex thoughts. Locked-in syndrome has been summarized here. Research has provided speech and language correlations to this syndrome as impairments in communication, feeding, and swallowing are apparent with this population. With the continuing technological advances in assisted communication devices, treatment and interventions with locked-in syndrome will continue to expand.